Hello, everyone, and welcome to the TMA Ask the Expert podcast series. Today's podcast is entitled Gaining Functional Recovery Through Occupational Therapy. My name is Gigi DeFibri, and I will be moderating this podcast. The TMA is a nonprofit focused on support, education, and research of rare neuroimmune disorders. You can learn more about us on our website at myelitis.org. This podcast is being recorded and will be made available on the TMA website for download via iTunes. During the call, if you have any additional questions, you can send a message through the chat option available with GoToWebinar. We want to thank the sponsor of this month's podcast, Alexion. Alexion is a global biopharmaceutical company focused on serving patients with severe and rare disorders through the innovation, development, and commercialization of life-transforming therapeutic products. Their goal to deliver medical breakthroughs where none currently exist is driven by the knowledge that people's lives depend on their work. For today's podcast, we are pleased to be joined by Dr. Kathleen Sikowski and Dr. Rebecca Martin. Dr. Sikowski is the new Senior Director, Patient Management, Care, and Rehabilitation Research at the National MS Society. In this role, she manages and is working to grow the Society's research focused on clinical and rehabilitation care, as well as development of the Society's wellness initiative. Dr. Sikowski has 15 years of experience as an academic scientist and clinician at the Kennedy Krieger Institute and Johns Hopkins University School of Medicine. Dr. Sikowski's studies have investigated the extent that nerve fiber changes in the brain and spinal cord are associated with changes in walking and physical impairments such as strength and sensation. Her research interests are to investigate the mechanisms that underlie sensory motor impairments and disability resulting from damage to the central nervous system so as to improve disability in people with neurologic conditions. Dr. Sikowski is also an occupational therapist with 25 years of clinical experience in adult rehabilitation. Dr. Rebecca Martin is the Manager of Clinical Education and Training at the International Center for Spinal Cord Injury at the Kennedy Krieger Institute and an Assistant Professor at the Johns Hopkins University School of Medicine in the Department of Physical Medicine and Rehabilitation. Dr. Martin received her Bachelor's of Science in Occupational Therapy from Boston University in 2001 and her Occupational Therapy Doctorate from Rocky Mountain University of Allied Health Professionals in 2008. Prior to joining the Kennedy Krieger Institute, Dr. Martin worked in brain injury rehabilitation in Boston, Massachusetts. Dr. Martin joined Kennedy Krieger in 2005 as a senior occupational therapist in the International Center for Spinal Cord Injury. Since 2010, Dr. Martin has been the Manager of Clinical Education and Training and is responsible for program development, staff training, and oversight of the clinical research program there. Dr. Martin speaks nationally on topics related to activity-based rehabilitation. She's taught many continuing education courses for rehabilitation professionals in the areas of neurological pathology, rehabilitation, and research. She's been the principal investigator and co-investigator for grants from the Paralyzed Veterans of America Education Foundation and Department of Defense to develop, promote, and disseminate an activity-based restorative therapy training program and curriculum. So welcome, and thank you both very much for joining us today.
Thanks for having us.
So to start, just to give people, who are listening a little bit of context about what the role of occupational therapy is and what occupational therapists do, Dr. Martin, would you mind just starting and talking a little bit about your role as an occupational therapist and the role of occupational therapists in general?
Sure. So most people are familiar with physical therapists, and a physical therapist's job is to evaluate your movement and help to restore specific movements. Mainly they focus around strength and endurance, whereas an occupational therapist's job is to take that movement and help you put it together using pieces of strength, endurance, but also cognition and coordination to engage in more meaningful activities. And so an occupational therapist is really going to center your goals around the activities that you want to do. So if bathing is important to you or feeding yourself, not just things like, can you bend your elbow, but really how you put those movements together. There's generally a greater concentration on upper extremity function by an occupational therapist than there is by a physical therapist. And an occupational therapist may also introduce modifications to the task or environment in addition to specific patient-centered interventions.
Great, thank you so much. And Dr. Zakowski, would you mind just adding to that if you have anything to add and talking a little bit about your role as well?
Sure. I think other things that come to mind, occupational therapy's role kind of evolves in a little bit differently at different locations. So at some institutes or clinical centers, occupational therapy may be heading up things like seating for wheelchairs. We also we often do, as Becca said, upper extremity care, including fabricating splints, as well as providing sort of exercise for upper extremity impairments. We also have training in things like how do you modify your home or how do you modify your work environment to be most efficient or most effective, given that you may need to adapt your activities a little bit more because of a pathology like TM. So we are sort of the people that should help you be able to do what you want to do with your life. And that's really very multifaceted, which is why I think it's always hard to define occupational therapy. We're not just the exercise people. We're not offering you medications. We're offering you adaptations and ways to make your life more, make you be able to enjoy what you like to do in your life. And so this makes it's a sort of a vague definition, but it's kind of on purpose because we really tailor the interventions that we provide to each person pretty individually, because your goals are very different from one person to the next. And so my role is I'm still in clinical care, but to a much smaller extent. So my role now is to really try to encourage occupational therapists and other scientists to study things that could benefit patients. So not only whether medications work or don't work, but also what kinds of rehabilitation interventions can be most effective and can help people with pathology like transverse myelitis. So my role is I have an administrative part, and I have a research part, and then I have a small clinical part as well. So occupational therapists can do a variety of things in addition to their clinical role.
Great, yeah, thank you so much. I mean, I think you both conveyed how much occupational therapists do and how varied it can be, at least in my experience as well, working with occupational therapists. They're there to help with, if I want to be more independent at working, at doing something, or just want to gain strength in certain areas, they kind of cover that whole, or knowing about adaptive equipment as well. So yes, thank you both very much for your insight on that. So I think we're going to jump into some of the questions we got from our community. So one question was that, these people put together a home exercise routine at home. Are there specific home exercises that are better than others, or what's the role of kind of a home program in occupational therapy?
You want to start, Becca, and then I'll add on, or do you want to invite
Sure.
you guys first and we can switch off maybe?
Sure. So I think that home exercises are really valuable and super important for people who have any kind of neurological impairment. Even if you're going to therapy on a regular basis, you might only be getting therapy for an hour, 2 hours, and in a really lucky situation at a time, a couple of times a week. But if you think about how much activity somebody with a normal neurological system is getting all the time, you need to be able to sort of replace some of that activity you've lost because of the injury or disease with some home exercises. So it's not enough to just go to therapy 3 times a week. You have to be putting in work at home. The World Health Organization recommends a minimum of 150 minutes per week of moderate activity for all people, and people with neurological disabilities rarely meet that goal. And so I always explain it to my patients like, you're driving a really special car and you got to put a lot of maintenance into this car now. And so it's not just what you do in therapy, but also your home exercises that become important. Things like cardiovascular activities like cycling or walking or using an elliptical machine are just as valuable for patients with neurological injury or disease as they are for a normal population. So that's something that should be included in everybody's sort of home routine. And then specific exercises are really dependent on your goals and deficits. So if you have a lot of weakness in your arms and your goal is to be able to feed yourself, your therapist can help you to identify exercises that will work on strengthening the specific muscles that will get you towards your goal. And then that becomes the things that you should work on at home.
Just to add, I agree with everything Becca said, but to add to it, part of the importance of going to an occupational therapist to get a home exercise program to improve your function is that it's the form that you use as you exercise, right? So anyone can sort of go, do exercise sort of haphazardly or not really thinking about it and just kind of get it over with. But there's evidence now that you have to be aware of what you're doing and do it with the right form so that you're getting the exercises to benefit you the way that we've intended it to. So it's really important to pay attention to what your therapist says, have them write it down, really be able to use the instructions that they give you, make sure you really understand them, and then try to set it up at your home as similarly as possible. I've even had people videotape themselves doing the exercise so I can comment on it, because it's really hard to know if you're doing the right thing. And if you're not doing the exercise really correctly, you're not going to benefit in the same way. I mean, it's similar to anyone who's done any kind of baking. If you're kind of haphazard and you don't put exactly the right ingredients in, you don't get the same product. So it's really important that the point of having a therapist give you exercises versus going to a gym and using a generic trainer is that we really are taking into consideration what limitations your pathology may have and what your goals are, and trying to combine that information so that you get the most out of it. It's not just something to take up your time. It's not just something to make you fit. It's something to make you functional. And that's sort of, I think, like an important part of what OT brings to this.
Great, yes, that makes sense. And I know it's also helpful for home programs too. I know at Kennedy Krieger Institute, you guys send people home with a home program that has pictures and stuff, which makes it a lot easier to recreate what you did in therapy at home as well. So that's always, I found that extremely helpful.
Yeah, and I think you should never, like Kathy just said, you should never be afraid to ask your therapist, am I doing this right? I often, when I see patients who I haven't seen in a while, the first thing I ask them to do is to show me their home exercises. Show me what you have been doing, and then be honest with me about what you haven't been doing so I can help fix that, right? If it was too hard or too easy or caused you pain, you need to make sure that you're talking to your therapist about that.
Right, because I think sometimes people will come back and say, this is just too easy. I decided to modify it because it was too easy for me. And sometimes the modifications are good, but sometimes there's a point to why it might be too easy. It might be that we don't want you to strain yourself, because when you start straining, you use extra muscles, and then you might not be getting the same benefit. So these little details are what I think make some people say, well, I just don't understand all this, so I'm not going to exercise at all, which I don't want to give that message either. But I want you to be kind of aware that exercise has some detail to it. It's really the way we would design a program for you is not the same way as you would get at a generic gym. It really is specific to what we're trying to get to. What's your improvement for? And so ask questions to your therapist. Make sure that you understand what are the important parts of this, and what can I modify if I do feel like it's too easy? How do I do that in the right way so that you are empowered to make some changes, but you really are, understanding what the ultimate goal is for it.
Kathy, am I allowed to ask a follow-up question, Gigi?
Yeah, of course.
Kathy, what do you recommend for people who don't have therapists near them?
Yeah, that's a really, really great question. I'm glad it gets brought up. So, ideally you get to an occupational therapist that has a background in neurology, and you get this expert. Otherwise, things you can do would be one thing I suggest to people is, can you get to a facility once for a good evaluation and to get the home exercise program, even if it's far enough away that you can't go very often, but you can at least access that expert in their clinic. Another way to do this is to go to a physical therapist and ask them, are there occupational therapists around? And if you live just too rural to have any of these clinicians very accessible and ones that understand TM, which might be much harder to find, part of it is you're going to have to do some learning on your own. And so that would be, understanding what exercises are going to provide you with increased strength in which muscles. So you can do a lot of this by looking online and reading, but I will give you, my caution is that the internet is a wonderful thing, but it also is not very well audited, so you can get information that is false or not correct, and you might not know that. So trying to learn what you can, but ask questions to the professionals you do have access to. If you have access to a physician, bring them your exercises and say, are these things that seem reasonable to you? They're not trained the same way a therapist is, but you can you can at least have that person make sure it's safe for you. Another good place to go would be a conference. So if the TM, I know they have conferences, you can bring information there and see if there are experts there that can talk with you. I don't know, Becca, do you have other suggestions? It's a really important problem.
Yeah, I think the one thing I would highlight that you just said is that if you're going on the internet, you can't just go to like Wikipedia and YouTube, right? You want to go to like the TMA website or the Kennedy Krieger Institute website or the MS Society, and those places will link you to other reputable websites to get resources and information from.
I mean, right, they even have the National MS Society has like videos you can follow.
Yeah.
To do basic exercise. And, I'm guessing, I haven't been on the TM website recently, so maybe you or Gigi can talk to what's available there.
So we do have several, we don't have any videos or anything that have particular exercises, but we do have several videos and podcasts about various rehab topics. And I do know also in my experience too, I have found some apps as well from different rehab centers that have different exercises and stuff depending on your level of injury. I don't know I haven't personally used them all that much, but I think those things are starting to come out a little bit more as well.
Yep.
There's a journal that is a video journal that I've published in with the goal of it allows patients to access the video, and what I published was an exercise manuscript trying to teach patients and or therapists specific exercises that are useful for people who have weakness in their hips. And so for adults that have weakness in their hips. And so I can make that available too, but it's definitely a resource with the purpose of trying to make it accessible to people across the board who might not have access to a therapist.
Yeah,
that sounds
that's great.
Good.
Yeah. And then, in terms of also, if someone doesn't have a therapist that specializes in TM, for example, with someone who just specializes in, for example, spinal cord injury or other neurological conditions, do you think they would be able to help someone with TM or NMO or EDM?
Yeah, I do.
Yeah.
And I think particularly people listening to this podcast and people who are a part of the TMA are really well educated about their conditions. And so don't be afraid to bring that to your therapist too and be like, I might be the only person you ever see with TM in Nebraska. Let me help you. Let me share what my experience has been with you.
There's also, you can go, So Becca is a really good example. So she works in a spinal cord institute. So it's really focused on spinal cord injury, but TM is one form of that, right? So you can generalize some of the information if you can get it from spinal cord specific resources. That might be also very reasonable for someone with TM.
Yeah.
Great, thank you. And then also, you did mention that the TMA has, we have a conference. So we do have a symposium coming up in October in Columbus, Ohio, where we will have talks about rehab and stuff. So definitely some information there as well. So going back to some of the questions, we did get a question about this person has had occupational therapists come to their home as well as an outpatient. And they found that some were more helpful than others when it came to walking. And they were just wondering, we've been talking about home programs. Is there something that they can use at home that can help them walk? They do have a walker, but are limited getting around without help. Dr. Zakowski, mind taking this one?
So the question is really, they're using a walker, but they want suggestions for equipment or for exercises?
I'm not sure. I mean, I think it's just they're looking for inexpensive equipment, they're saying, but I think also we can expand it to others who this might be relevant for in terms of exercises that help, particularly with walking or things that can be done to help with gait.
So two things come to mind. One, I'm a big advocate of standing frames. When people have trouble walking, even just standing is an exercise. And so you can just stand at a counter and watch TV or play cards or do something with someone else. And that act of standing is exercise, especially if you're kind of aware of your posture and you're not leaning on the counter the whole time, but you really are trying to hold your weight on your legs while you stand. That's one good way to get exercise in an environment where you might not have a lot of help, but you still want to be doing something for yourself. And you can stand independently against, holding onto a counter, and it can progress all the way to these standing frames that provide support so that you don't have to do nearly as much, but it provides support at your knees and your hips and your torso. And that allows you a safe place to stand and get some exercise. It's not only good for your leg muscles and your trunk muscles, but it's good for your blood pressure and things like that are sort of a physiologic response that you get from exercise as well. Now, if you're asking about exercise and the need for expensive equipment, that is not necessary. I mean, there's more and more evidence that just plain physical activity, any kind of physical activity that you enjoy, is better than sitting on the couch or sitting in a chair the whole time. So if that means that you have to go in your wheelchair and use your arms because that's your way of getting physical activity, that's great. It also could mean I'm always gonna walk to get the mail. I'm not gonna ask my significant other to get the mail. I'm always gonna do it myself because that's a little bit of a walk. I'm gonna make sure I walk around the block once a day to make sure I get a little bit more exercise. So exercise can take on the role of just being activity, something you're doing so that you're using your muscles in your body and you're moving. Or it can be more focused and be more exercise driven, where you're sitting on a stationary bike and you're cycling, because that's one way you can do it safely. There's no risk of falling on a stationary bike versus walking might pose a risk of falling. And if you're alone, that might be not a good option, right? You don't need equipment to do resistance exercise. And we all know there's so much evidence that as we age, we need to all be doing resistance type exercise as well as the endurance exercise. So anyone on the call that's older than 40, we should all be doing some kind of resistance training. And you want to be very careful how you start it, but you don't need equipment. You don't need expensive equipment. You can get hand weights that are very small, 1 or 2 pound hand weights, up to 5 pounds. You want to, again, be sure you're doing things safely so you're not causing yourself pain. We also use in the lab, we used resistance bands quite a bit. And we found very good success at just using resistance bands that are anchored to a door or anchored to your sofa, something that was not going to move very easily and that you can pull up against and do specific exercises. So the window is wide open on how you can get exercise outside of expensive equipment, and you don't always need a walker to get exercise. You can do things outside of walking that can provide some improvement. I hope that answers the question. And Becca, you might want to add to that.
Yeah, I think the only other thought I would add is that a lot of gyms in the communities have adapted exercise equipment, particularly at YMCAs. They make a big effort to include people of all abilities. And so you'll see a lot of things like recumbent cycles or even arm ergometers or cycles that you can use. And that often winds up being much less expensive than buying one of those pieces of equipment for yourself at home.
Right, that's a great suggestion. And then, just looking at the questions. When talking about weight training and weights, we did have a question asking if weights are a good way to gain strength back, and what would be a good routine to follow. Would you do heavy weights and few reps, or lighter weights and more reps, or does this kind of vary based on the muscles or what the goal is?
So I think the most important thing when it comes to resistance training, like Kathy just said, is that you have to do something. And so if you can do 12 repetitions at 3 pounds instead of 5 repetitions at 10 pounds, then you should do what you can do the 3 repetitions or 3 pounds and 12 repetitions. There is a role for both low weight, high repetition and high weight, low repetition when we're talking about conditioning muscles in a particular way. And your therapist can help talk you through those and what phase you really need. But I don't want to tell people like you should only do it one way, because the fact is they're both important, but something is better than nothing.
Yeah, I second that. I think the excuse, which I still think is an excuse, whether you have TM or you don't, is that you do nothing. So there's always something that you can be doing that is safe and healthy for where you're at. It's finding out what to start with that I think is often the big the thing that stops people.
Right.
Also, I think that people, particularly people with some sort of injury or disease, are often afraid to be uncomfortable, and exercise and resistance training, it shouldn't be painful, but it's probably not going to be comfortable, particularly when you first start. So that's where a therapist comes in really handy, because they can really help guide you about what's pain versus what's discomfort and what's safe for you and where to start. But you should expect for it to be difficult.
That's a really good point. Actually, I feel like people should really listen to that, because I have found even just with normal aging that exercise gets to be more uncomfortable as soon as you stop doing it for a while. And
Yes.
So just because you have any pathology doesn't change that normal part of aging, where just moving more becomes more effortful as we get older. And so it's more of a reason why we have to stay fit and not go through these cycles of I'm gonna exercise and then I drop and I don't do anything for a month, and then I'm like, oh no, I gotta start it again. Because that's much more effort than if we can try to find physical activity and exercise that you enjoy enough to keep it going and throughout the year, right? So keep it going, even if you have to modify it with the seasons. So I can't be outside walking in the winter because of the snow. How am I going to adapt that so that I have an equivalent kind of thing that I can do indoors safely and within my set of resources, right? Can I walk in a mall? Can I go to a gym like the YMCA? That's a really good suggestion. Can I use free videos online to do exercises in my home? Can I invite a neighbor over so that I'm more apt to actually do the exercise? Thinking really creatively is not specific to TM, and it's a problem for everybody. But having a disease just makes it even seem a little more daunting, is my guess.
And here's the really good news, the really exciting part, right, is that there is a lot of evidence to show that activity into the nervous system, so increasing the amount of input you're giving your nervous system through exercise and activity benefits your whole nervous system. So if you, for example, have a really difficult time walking and you're able to do exercises just with your arms, you will find over time that you might be able to do more exercises with your legs also. And again, a therapist can help you guide these things, but Kathy's point about picking an exercise that you like and you will stick with is really the most important part. And that you'll see changes in your nervous system and your body and your muscles and your joints and your bones, and all of these things will start to come, and they'll come through your whole body too.
Right. It's exactly, and there's evidence, right? We know that that exercise can help with depression, can help with cognitive changes. All of those things are benefits that have very few side effects versus the many medications that have this list of side effects. So you might benefit in one thing, but the cost of it in side effects alone is very difficult. So exercise doesn't have that long list of side effects, especially if it's done under the guidance of a therapist.
Thank you both. We also got a question about deep tissue massage therapy. So, some pain has been alleviated for this person who asked this question, along with some numbness and the girdling feeling in the abdomen. So is there, is that something occupational therapists, or do they ever do kind of massage therapy? Is that, or is that a different specialty, or how does that kind of play into the role of occupational therapists?
So I'm not sure I understand. I couldn't understand all the words that you just said. So you're saying if you have sensory changes, is that what you mean? If you have sensory changes like numbness, how does that affect exercise?
Oh no. So this question came from someone who was diagnosed with transverse myelitis in 1989. They're now 72, and they've been doing deep tissue massage therapy recently. And it's been helping with pain and numbness and the girdling sensation that some people experience. So I was just wondering if massage therapy is ever part of what occupational therapists do, or if it's something separate, or if it does play into the role of occupational therapy. You're able to hear me that time.
Thank you. I understand now. So from my experience, massage therapy is not part of directly from occupational therapy. There are massage therapists who have training. We have some training in massage, but it's, in my experience, it's been more specific to massage for scar tissue. So Becca might be able to give you a different version of that, but there are massage therapists who are trained to give massage, and the evidence for its effectiveness is very, very spotty. So that is what's going to limit your insurance company in many cases from covering it. But I'm not saying it doesn't help many people. I have a lot of patients who have said it's something they really benefit from and they don't want to stop. And so I don't find it under the occupational therapy realm in my experience.
So I think when occupational therapists do more manual work and more of something called myofascial release, which is addressing the tissue that lives between your skin and muscles and sometimes causes restrictions in movement, which is not traditional deep tissue massage like this person is describing. It doesn't feel good, and but can help to break up a lot of restrictions and free movement. That would be something that a skilled therapist does, which is different from massage therapy. although I agree with Kathy, and if it makes you feel better and therefore gets you to move more, I'm in support of massage therapy.
Right, that makes sense. Okay, and then going back to, we kind of had a follow-up question to what we were talking about earlier. So, you know, so we were talking about how there's like, should be, or often is some level of discomfort when doing exercise because, you know, you're doing exercise, you're working out. You know, we just got a question about this sort of discomfort. Is there a connection to overheating with exertion that triggers symptoms? This person has exerted themselves and found that they feel dizzy, tingling in their extremities, you know, anxiety sensations in their chests, numbness, and that sort of thing. So can exercise kind of lead to that overheating that then leads to these symptoms?
So from my understanding, when you exercise, there's a physiologic response. And we know in multiple sclerosis specifically that when you warm up your body using exercise, this changes the structure of myelin. And so this causes many people with multiple sclerosis and maybe TM, even though the pathology is different, but we all have myelin, which is the covering around the axon. That myelin structure changes as it heats up, and that can allow people to feel symptoms that they have felt in the past. And as soon as they cool down, they finish exercising, they will go back to their baseline. So it won't cause the pathology to progress in any way, but it can definitely be very uncomfortable, and many patients describe it as just sort of scary because they don't want to feel this tingling or numbness or these sensations that they felt in the past. And so in my experience, that is different than the discomfort we were talking about when you're exerting yourself. You want to have a little bit of muscle fatigue, for example. You want to be out of breath a little bit. You want to maybe have some sweating. Those are the positive physiologic responses to exercise that you need to learn to be comfortable with in order to make gains. But if you're getting dizzy when you're exercising, that's more dangerous. So that is something that you need to monitor, maybe your blood pressure as you're exercising. You need to be sure you're drinking enough water because even just being dehydrated can make you dizzy when you exercise. And dizziness is important because then, of course, if you're dizzy, you might fall, right? So then there's a higher risk of injury. And you don't want to put yourself at higher risk of injury when you're exercising, of all things, right? Exercise is supposed to be helping you. So if it's done smartly, you know, you shouldn't be putting yourself at greater risk of falling. We need to make sure you're in an environment that is safe. But there is going to be discomfort from exercise, and that's what I was trying to sort of spell out, maybe some of the differences.
I'd agree with all of that. I think, too, we talk about the discomfort that you're experiencing during the exercise, a rise in your heart rate, exerting your muscles. And as Kathy described, all of that sort of goes away when you stop exercising. You might feel it for sort of 20 minutes, maybe even 24 hours if you had a particularly hard workout, but it should resolve and go away. And I think sometimes people with MS or TM are afraid to exercise because they're going to worsen their pathology. And as Kathy described, that changes related to exercise resolve.
Right. And is it possible too that someone would get something like autonomic dysreflexia from exercising? And would that kind of present similar symptoms, or is that something else entirely?
It is very possible that somebody gets something like autonomic dysreflexia in response to exercise. Again, that would be something that resolves pretty quickly once you discontinue the stimulus that caused the dysreflexia in the first place. And that's, again, another really important spot for a therapist to help you tease out what it is that you were doing that caused the dysreflexia, and then how to modify or change that activity, but still get similar benefits.
Right. That makes sense. And then, so we also, one of the big things I hear people talk about is issues with bladder and bowel problems. And so this, we did get one question about, that when this person's mother was diagnosed with TM, she lost bladder control. and now has a catheter that's attached to a bag, and it's impacting her self-esteem and socializing. Is there a role in occupational therapists in terms of helping patients, manage bladder and bowel issues or strategizing ways to do that?
Yes, so I think there are sort of two avenues here. One is function of the bladder and changing that, and two is managing the bag, the dressing, the hygiene associated with having a catheter. So in that second area, things like if they're really, the bladder has lost full bladder control, the patient has lost full bladder control, but doesn't like having an indwelling catheter, which requires you to have this external drainage bag, the therapist, in conjunction with the physician, might help you make the decision to move to something like an intermittent catheterization. And that an occupational therapist could help you learn how to do that, how to set up your environment, how to transfer in and out of your wheelchair, manage your clothing and your hygiene, all of those sorts of things, so that you no longer have the drainage bag, but could empty into some sort of container and then get rid of that urine on a regular basis. So OTs can help in that way, in terms of like modifying how you're managing your bladder. There are also therapists, PTs and OTs, who have specialized training in pelvic floor health. And so if there is some bladder function remaining, and that would need to be decided by a doctor with a urodynamic study, but if there's some bladder function remaining, there are therapists with specialized training who can help to retrain the muscles of the bladder and the pelvic floor to restore continence.
Right. It's a really difficult problem to address, and so the use of sort of the very coordinated use of medication, as well as management or adaptive measures, is going to be what's going to be probably the most effective. So I think this is where having a physician and a therapist involved might be the best solution.
Right, that makes sense. Having a team kind of coordinating different aspects of someone's care. Great,
right.
Thank you. And then, sorry, just looking to see. So we've talked a little bit about therapy as trying to get back function, as well as kind of adapting your life to do things a little bit differently, to be able to accomplish things in sort of a different way. Are there any, is there any evidence that this occupational therapy or any sort of therapy can help kind of regrow myelin or repair those connections that are damaged, like like electrical stimulation or gait training or anything like that?
Do you want to start back in and all that, or do you want me to start?
I mean, you're the myelin expert, so you can go first.
So we know. So it's a golden question, right? Because if I were to tell you there's this one thing that you could do, and that would increase the growth of connections in your spinal cord, everyone would want to do it. And the reality is we don't have that, podcast. Right? Yeah. But there is hope. So I will tell you that. I know there is evidence that that motor learning can happen. New motor learning can happen in an adult. So initially, we thought this only happened in children during development periods, but now we know if you have damage in your brain or spinal cord, you can make changes that are activity driven. What we don't know is the exact dose you need. We don't know how to, we're not very good at tailoring this to each individual just yet. But there is evidence in animals and humans that exercise can be a trigger for this. It changes the chemical makeup of your spinal cord so that you are putting yourself at the best possible position to remyelinate and facilitate new connections neuronally. And I'm not speaking generically like this on purpose as much as I want to be very clear. We do know that it can happen. We just don't know, as far as I'm aware, the details of exactly what you need to be most effective. And the reality is that probably each one of us has a different amount of potential for regrowth and change in these neuronal connections. And so when you're an adult with transverse myelitis, this is good news, right? Because this suggests that there's hope for just using activity. What I think is the most realistic response is that activity, probably plus some kind of medication, is going to be what we're going to find is going to be most effective, but we don't know that that dynamic very well just yet. And so my best advice to people is to stay as active as you can. So physical activity can't be passive for these changes to occur in your brain and spinal cord. They have to be you're actively thinking about what you're doing as you're exercising, pushing yourself to a certain extent so that you're facilitating your body to work at its most healthy way. And so my guidance again would be to go to your physical therapist and occupational therapist to get yourself as active as possible and figure out what kind of exercise you can continue with. I don't know, Becky, you have more specific examples, I think, probably from the Spinal Cord Institute.
Yeah, so I always describe it because I'm not as smart as Kathy. I have to think about it in more simple ways. And so I think about it as they're a little Pacmen in our nervous system, inside our spinal cord and our brain, whose job it is to eat up damaged cells and lay down new cells. The thing is that those Pacmen only go to axons or wires that are active. And so when you have a neurological injury like a spinal cord injury or transverse myelitis or MS, those axons go dark and the Pacmen don't know to go there. And so like Kathy was saying, what we do know is that activity, specifically below the level of the lesion, but also above, helps to turn on those axons and direct those Pacmen. What we don't know yet is how much activity they need and how long those Pacmen are going to take. We have some better evidence in animals, but unfortunately animals are not humans, and so the rules don't apply the same way. So our program is built around this idea of providing repeated near normal levels of activity into the nervous system to optimize the nervous system for recovery, turn on those axons and get the Pacmen to do their job, and offset the rapid aging and chronic complications that patients with spinal cord injury and transverse myelitis and MS and NMO have. And so all the things we've been talking about up to this point in this podcast have been surrounding the physical integrity of your body, making sure that you are healthy, that your muscles are working, that you prevent breakdown of your muscle and your bones through exercise. And as Kathy was just describing, it turns out that same exercise is what you need to mobilize the body's own capacity to repair and regenerate that myelin. We do, therefore, a lot of electrical stimulation to get body parts moving that are not able to move on their own. Also things like vibration and in certain structured exercises. But like Kathy said, it has to be active. You can't fall asleep during therapy. That's why massage therapy doesn't count as active occupational therapy, right? You can't just have somebody come in and stretch you. You have to be making the effort too, because there needs to be a coordinated down message and up message in your spinal cord in order to turn those axons on. Our current research is looking at a particular kind of stimulation that is applied across the surface of the skin, but directly to the spinal cord, which helps to unmask hidden connections. So we know that in all cases, particularly in cases like transverse myelitis and MS, there is a fair amount of preserved tissue still in the spinal cord. But it's not communicating with enough volume and coordination to restore normal function. And so this stimulation that we're providing to the spinal cord helps to basically turn up the volume on those connections, allowing them to be more efficient in their communication. And so we're seeing that patients are recovering walking, recovering sensation, bladder function, things like that, in response to this stimulation plus therapy. So it's not enough to, again, to just wear the therapy and be a passive recipient. It has to be or to wear the stimulation and be a passive recipient, it has to be in combination with therapy. So that's the kind of stuff that we're researching now. Again, there's a lot of questions about dosing and timing, and do you need to do it forever? Is it like a vitamin you're going to have to take every day for the rest of your life? Or once you can walk, will you be able to walk for the rest of your life? And we don't know those answers yet. But that's what we're working on now. We also don't know, I guess, sorry,
go ahead,
we also don't know, to the original question, whether this recovery of function is related to improvement in these hidden connections, right? Unmasking these hidden connections, or if we're actually remyelinating or regrowing axons that were lost to the original injury. And we don't know that because people are really resistant to let us dissect out their spinal cords. But maybe one day we'll have a better answer from a more animal-based model.
I was going to bring up other experimental things that we've done besides, dissecting out your spinal cord, which sounds a little painful. But,
yeah.
So we just did a study with Mike Levy where we had patients with TM use a combination. So they used a derivative of 4-aminopyridine, which I can't think of the regular name if one of you can think of it.
Ampera.
What is it called? Ampera, yes, Ampera, thank you. Yes. So they use Ampera, and we were trying to figure out so Ampera is known in multiple sclerosis to improve walking in patients with MS to a small percentage of people. It doesn't work on everybody. No one has any idea why it's working, but it's FDA approved for this particular thing. So we thought, well, in TM, why don't we see what we can do? So what we did in the laboratory is we tried to probe whether the neurons were changing as the people were on this were on Ampera. And I'm not going to give away the whole answer because Mike and I are writing the papers right now, but I can tell you that there are things going on in the laboratory. So if you hear about experimental studies and they're looking for patients with transverse myelitis, you're all a very rare group. So find out more information about it. See if you're truly interested in it. There is no pressure that you have to do it, but it might be something that would help us understand the disease better, and in that way we would understand how better to intervene and make improvements. And the study that we did was very safe, but it required a lot of effort. So patients had to literally take this medication, but they also had to come into the laboratory for a 3-hour visit. Then they had to keep taking the medication, come back a few weeks later for more testing, go back home, keep taking the medicine. And this went on for 8, 12 weeks. And so this is a big investment in time, but it is the way that we're going to better understand how the medications work and what's going on in the brain and spinal cord, MTM specifically, when you are active or not active. So I definitely would encourage you to read the paper as it comes out, but we're finding, so we used a technique called transcranial magnetic stimulation to kind of probe the brain and spinal cord as to how healthy those neuronal pathways are when you take this medication. So I tell you that more just to offer options of things that you can do that might make everyone, make you feel a little bit more like you're on the cutting edge of what's going on with this, with transverse myelitis or any other pathology that you may have. Studies are ongoing, and the more you know about them, I think the better, because then you can make choices on whether you want to be involved or not, but you can at least learn what they found out, even if you're not involved.
Yeah, so Kathy, I always direct patients to clinicaltrials.gov.
Yeah, that's good.
Which is a great website. It lists every clinical trial going on in the country that is recognized by the FDA. And so at any of these academic institutions, like Johns Hopkins, we have to go through an institutional review board. And as part of that, we have to post our study to this clinicaltrials.gov. And so you can find studies going on all over the country and in some different parts of the world, even depending on their FDA approval. And and it will tell you what population they're studying, what the intervention is, and then they're required to post updates occasionally too. So
That's right.
in big trials, you'll be able to see what kinds of things are coming out and going on. And so that's a great resource. Like Kathy said, even if you don't want to be a part of a study, it's great to sort of look at what's going on and what's happening in the community.
Right, and also the TMA, we always list the clinical studies and trials that are going on that are related to TM, NMO, ADEM, or optic neuritis as well on our website. Oh, cool. And then we also try to do literature summaries of peer-reviewed literature if people don't have access to journals. So those are also available on our website as well. So it's always exciting. And it's yeah, there's a lot of opportunities out there as well. So
that's great.
So I know we're getting kind of towards the end of our hour. Was there anything that we didn't discuss that either of you feel like we should have mentioned, or kind of any last thoughts about the role of occupational therapy?
One thing I always tell my patients is that recovery is activity dependent, and putting your pants on counts as activity. So sometimes people think, oh, I need to have somebody else come in and help me with my cares and get me through my morning stuff and feed me and get me dressed and all these things so I can go about doing my therapy. And I try and shift that focus to, like, every time you move, every time you make an effort to do something that you didn't do yesterday, no matter how small, that is therapy. And that is the activity that we're talking about that is going to change your nervous system. It's not the 30 minutes of exercise that you're doing. It's not the twice a week you come to therapy. It's every day trying something new.
Right, and there's lots of little ways to kind of motivate people to try to stay active, right? There's the stuff on your iPhone, the apps on the iPhone that you can get for free that can monitor where that iPhone has been. So keep it in mind that that's just measuring where the iPhone goes. There's also, the wrist-worn accelerometers like Fitbit that you can wear, and you can wear those on your wrist, or you can wear them on your ankle or around your chest. And this measures where that thing goes. So if you wear it all the time, you can have an objective measure of where that has been. And if it stays on your body, then that's where you have been, right? So this is a way to sort of monitor, I guess I equate it similar to weight loss. Even if it's just a few steps, but you're doing a few steps more all the time, or a little bit more activity, that's progress. And that's the kind of thing that you want to help motivate you so that you can stay moving and not just give up and have those couch potato days too often or too many in a row.
Yep.
I think these kinds of discussions are really important to have too. Like, I'm glad that the focus was on something like occupational therapy, because I think the focus so often is on, what medication is going to work, or what kind of physical therapy is so relevant. But occupational therapy, I think, doesn't always get the center stage, even though our job is really to try to help keep people functional. And that's everyone's goal, right? So I appreciate the TMA just having sort of the interest in really focusing on occupational therapy.
Agreed. I think it's super important too, because, walking is a really hot topic, right? It's the thing that everybody wants. But what people forget is that if you can walk, it doesn't mean that you're going to be able to do everything else anyway. So a lot of my patients, particularly young teenage men, come in and they think that if they can walk, they'll be able to tie their shoes and put their pants on and brush their teeth and type on the computer and cut their food. And that's not necessarily the case. That your therapy really needs to be well-rounded and geared towards the things that are most important to you. And that doesn't have to be walking.
Right. I think that's
I agree.
A really important point. I mean, people assume, when you have some sort of paralysis that, walking is the ultimate goal, but there's so much more in life. So I'm very glad you brought up this. There's a lot more than just that. So yes, I appreciate it. I appreciate your time very much. We did get a comment that the podcast was very helpful and that they're thanking us thank you all for the information. So from our listeners. So thank you both very much. And just a reminder to everyone that this will be available on our website, in our resource library, and on iTunes as well. So thank you both.
Thank you.
Thank you.